Hello, I'm Matthew Bunte, and I'm the Director of Vascular Medicine at St. Luke's Mid-America Heart Institute. I'm pleased to present BTK Solutions. I have no disclosures. When we're talking about below knee disease, we're really referring to treating the CLI population. The CLI population is known to have multi-level disease, commonly involving the femoral popliteal segment as well as the infragenicular segments, which can be quite small and challenging to treat. At the end of the day, we know that wound blush, improvement in toe systolic pressure, and an absolute increase in skin perfusion pressure at the wound bed are the predictors of reduced amputation risk. Medial artery calcinosis is a primary below-the-knee challenge, often associated with a sicker, more comorbid population with misleading diagnostic testing, primarily associated with non-compressible ABIs, and unique challenges in dealing with calcified small artery disease. The characteristics of below-knee disease have perhaps been best studied in this meta-analysis of over 50 studies over a 20-year time period. Nearly 9,400 lesions were analyzed where anterior tibial location was the most common. Most patients had Rutherford 5 and 6 ischemia, and the mean reference vessel diameter was 2.7 millimeters with a mean lesion length of 105 millimeters. Many patients were calcified and had occlusive disease. In this same meta-analysis, the authors confirmed the limitations of contemporary balloon angioplasty for below-knee disease with a primary patency at 1 year of 63.1%. Despite these challenges, endovascular revascularization remains the mainstay of revascularization for CLI, and with endovascular rates rising, we have seen reduced amputations and rates of surgical revascularization declining. There are multiple endovascular tools now to manage long lesions and calcification that have limited primary balloon angioplasty. Over the last decade, drug-coated technology has been studied in multiple randomized trials with clear evidence of the advantages of balloon expandable drug-eluting stents over plain balloon angioplasty or bare metal stents. However, the limitations of balloon expandable stents, particularly in the distal tibial segments, is clear, and most recently drug-eluting balloons has been a subject matter of interest. Initial excitement was gained with drug-coated angioplasty for below-knee disease from the DEBATE BTK study, which was a randomized open-label single-center study comparing drug-eluting balloons and conventional angioplasty. The study was done in patients with below-knee stenosis or occlusion greater than 40 millimeters, and at 1 year showed superiority for the drug-eluting balloon. However, these results did not hold up in the multi-center randomized controlled trial of IN.PACT DEEP, which studied 358 CLI patients randomized 2-to-1 to drug-eluting balloon versus conventional angioplasty. At 1 year, the efficacy endpoints of late lumen loss and target lesion revascularization were no different, and there was a concerning signal of an increased harm with a 6-month composite safety endpoint of major amputation, all-cause death, and revascularization higher in the drug-eluting balloon cohort. Most recently, the 5-year outcomes for IN.PACT DEEP were published and confirmed no difference in target lesion revascularization out to 5 years. However, importantly, there was also no difference in mortality for the drug-coated balloons, nor was there any late amputation signal for drug-coated technology. Atherectomy for below-knee disease certainly has a role, and there are varied tools to apply to calcification or long lesions to help achieve optimal results, although there are significant limitations including distal embolization and vessel perforation that are not to be discounted. A technology of considerable interest is intravascular lithotripsy, which is an alternate to high-pressure angioplasty or atherectomy. And in a safety and feasibility analysis of 20 calcified lesions, the technical success rate was high. There were no significant adverse events at 30 days, and all patients had less than 50% residual stenosis. The benefits of intravascular imaging translated from PCI may be directly applicable to below-knee intervention. As angiography frequently underestimates vessel size and complexity, IVUS can be helpful in identifying distal targets for wiring and treatment, and has been shown to reduce post-procedure complications and amputation rates. Tibiopedal vascular access is perhaps the most important advance over the last 20 years in dealing with below-knee PAD. There are several advantages, including anterograde and retrograde visualization with shortening of the chronic total occlusion, easier distal cap crossing, and rail support with wire externalization. Imaging guidance is a requirement, and preparation and positioning the patient such that tibiopedal access can be rapidly deployed during intervention is important. These tools have been incorporated to develop algorithms for treatment of chronic total occlusions, and I think incorporating all of these tools and solutions into complex BTK treatment is ideal. But what about surgery and the potential role for bypass? Well, we know in this analysis from the Vascular Quality Initiative that patients receiving endovascular revascularization tend to be sicker and have more comorbidities. Lower extremity bypass is offered more commonly to those with prior revascularization, although bypass patients also have higher rates of acute procedure complications, length of stay, and 30-day mortality, with no benefit in major adverse limb event endpoints at 1 year. The BEST CLI trial, which is now in follow-up phase, will provide additional insights into endovascular and surgical treatment with a mission to maximize interspecialty collaboration. But what about options for patients who have no distal targets for revascularization due to heavy calcified occlusive PAD? Such patients are otherwise relegated to major amputation. Deep vein arterialization may provide such an option with retrograde pedal perfusion via arterialized midfoot pedal veins. As you can see on the cine angiograms on the right, the 90-day angiogram confirms midfoot retrograde arterialization of the tissue and capillary bed. This technique requires inflow into the proximal tibial artery and adequate pedal vein outflow, with close monitoring of the arterialized venous fistula and some modification of wound care, including dressings that are not too tight. And forefoot ischemia and swelling can be issues with this technique. However, the results initially have been encouraging for deep vein arterialization, with an 80% freedom from amputation in the ALPS registry over 24 months, and more recently presented the PROMISE 1 study results showing a 6-month freedom from amputation rate of 76%. So in conclusion, complex below-the-knee disease deserves a personalized and systematic approach, with large multi-center prospective studies needed to provide uniformity in treatment standards and outcomes to advance infrapopliteal treatment. Novel and improved revascularization therapies for below-knee disease offer solutions that will enhance wound perfusion and optimize outcomes. Thank you.